Hello, everyone, and thank you for joining us. This is Meredith Radell from Palladium. I am delighted to welcome you to today's webinar, Investing in the Health Workforce to Improve Health Outcomes at the Community Level. We have a great broadcast for you today, and we'll begin with just a few announcements. This session is being recorded, and we will post the recording to PROPEL Health's events page. We would love to hear from you, and we welcome your questions at any time. Please submit your questions via the Q&A feature on the top right side of the meeting window, and our moderator will read them aloud when we pause for questions. Finally, we ask that if you are not speaking, please mute yourself to keep the line nice and quiet while others are talking. That concludes our announcements portion, and I'll now turn it over to Veena Menon, PROPEL Health's AOR.
Thanks, Meredith. Thank you so much. Welcome to everyone. We're very excited to present some of the work that we've been doing under PROPEL Health to you all today. Just a few words on the importance of health workers. I'm preaching to the choir here, I realize. We all know about the launch of the White House Global Health Worker Initiative, and that has prompted greater recognition of health workers as the backbone for the achievement of all of our global health program goals. And here at USAID, we see primary healthcare, where the majority of services supported through our programs come together, and this multidisciplinary workforce, including community health workers, as priority, which is why it has been incorporated as a key component within primary impact. So enjoy today's presentation. I'll hand it.
And hello, everyone. Let's hope that we don't have the same with issues, but if so, just raise your hand and I'll take that hint. My name is Jorge Ugas. I'm the Director for Health Economics at Palladium and also the IR1 lead for PROPEL, which is the policy IR. It is a pleasure to share this space with all of you today and shed some light on the work that we at Palladium and at PROPEL have been doing on HRH, along with this group of insufficiently recognized players in our healthcare systems. And I echo Veena's words of preaching to the choir, but the community health workers. But in this case, the idea of this webinar is also to bring a focus on policy advocacy, financing, and governance. Next slide. Okay, next slide, please. That's the one. Okay, perfect. So community health workers, or CHWs, as we know, they play a pivotal role in improving health outcomes where access to quality healthcare is limited and often very, very limited. And yet, as we know, despite the invaluable contributions, they continue to face numerous challenges and obstacles that hinder their effectiveness. And today, the idea is that we will search for some answers by focusing on a few interesting country examples. CHWs, they represent a cost-effective way to reach households in rural and hard-to-reach areas where it's either distance, lack of transportation, financial constraints, often prevent individuals from seeking medical care when they need it most. And this is where they step in, right? These workers, they sort of like bridge the gap between communities and formal healthcare systems, or at least that's the intention. Delivering essential services right to people's doorsteps, educating communities, etc. They're sort of like a trusted liaisons, right, between healthcare providers and communities, with very deep understanding of local costumes, languages, cultural beliefs, and what we're seeing is that what we know is that this is crucial in overcoming barriers to healthcare, such as stigma surrounding certain illnesses, and sometimes, as we saw with COVID-19, reluctance to seek medical help. And by fostering trust and rapport, community health workers empower, and I want to emphasize here the word empower, individuals to make informed decisions about their health and also their well-being. Next slide, please. Needless to say, they face numerous challenges, and these challenges threaten their effectiveness, threaten their well-being, as we will see in the next few minutes. Challenges, we must know those, right? There's a lack of adequate training and essential medical supplies and equipment. And without them, they will struggle to provide quality care, and that ends up compromising health outcomes in the communities that they serve. They are frequently undervalued, most of the time underpaid for their work, receiving meager compensations, in some cases no compensation at all, as we will see as well. And this not only undermines their morale, but also makes it difficult for them to support themselves. Many may be deterred from pursuing a career as community health workers, which exacerbates workforce shortages. And moreover, and this is key for our discussion today, and this is key for the direction that we're taking Propel on, is that community health workers are facing significant challenge in terms of their integration into formal healthcare systems. Their contributions are often overlooked by policymakers, by healthcare providers, and that hampers their efforts to integrate them into broader health systems, which ends up limiting their ability to work with other healthcare professionals. And with Propel, we have understood that message very clearly from the very beginning. Through our work on primary healthcare, we cannot and we're not underestimating the power of community health workers in shaping the impact of our programs, but also of the future of global health. And with a particular focus on policy, on financing and governance, we're making sure that we can maximize their potential impact. So let's take a brief look at what we're doing under Propel. We'll spend a couple of minutes in Cote d'Ivoire and then just a brief mention in Botswana. Next slide, please. So Cote d'Ivoire. So by the end of 2023, just to give you an idea, in Cote d'Ivoire, they had one community health worker per 1,700 inhabitants, which is way below the standard that was set by WHO and also agreed by the government of CDI of one community health worker per 250 or 500 inhabitants. So very important shortage of approximately 35%. So Propel conducted a situational analysis in order to identify the sources of funding and provide information that will enable the government of CDI to take ownership, of CHW financing. Challenges that were identified. First, the official legal classification of CHWs as volunteers rather than health workers. And this is common across so many other different countries that we looked into. And there's also some resistance on the side of the Ministry of Health to change their status. And in this case, CHWs that are not linked to health districts by formal contracts, which means that they cannot receive social benefits. And as we know, status is linked to recognition, and which is linked to morale, which is linked to worker satisfaction, and also to the likelihood of staying in the job. The second key challenge, and also linked to the type of work that we're doing in Propel, is insufficient financing. The government of Cote d'Ivoire does not currently contribute to the funding of CHW's stipends. The payment for the CHW's stipends depends almost entirely on Global Fund, UNICEF, PSI, PMI. And when we interview some of the workers that we interview, they ended up reporting frequent irregularities and also, which is more worrisome, delays on the payments of their stipends. And in some cases, they will end up receiving stipends at levels that are below the minimum wage. Two other challenges: lack of coordination of stakeholders, poor availability of medical commodities and equipment. Next slide, please. So as part of that situation analysis, our team also looked at the effect of climate change on CHW's working conditions and services. And it was done because doing this type of analysis is crucial to understand how climate change is and can be affecting all sorts of dynamics within the health systems. And the nature of the work done by CHWs is no exception. In this country, climate change is manifesting through extreme heat, changing rainfall patterns, rising sea levels, severe droughts, extreme weather events, and all of these impacts through different channels have the potential to severely affect the effectiveness of the work of the community health workers. The team also found limited understanding among stakeholders of the links between climate change and the work of CHW. They have some sort of like a myopic vision on how community health workers can be a powerful agent to foster adaptations or resilience to the impacts of climate change. But I also have the suspicion that this sort of like myopic vision applies not just to health workers, but in general, in terms of the links that we are discovering and really understanding between climate change and health systems. And also, as we know, climate health workers, community health workers, they are not being trained or equipped to handle climate-related issues in particular. Next slide, please. So in order to start drafting a policy agenda and recommendations for the Ministry of Health in Cote d'Ivoire, in just a couple of months ago, PROPEL co-facilitated a stakeholder consultation with multiple people and different type of entities attending. And they basically look at the results from the situation and analysis, share inputs, discuss potential policy agenda, and identify barriers that may hinder the proper implementation of any policy agenda linked to community health workers. Next slide, please. So in terms of next steps in Cote d'Ivoire, first, there's a need to support a local organization to conduct advocacy to improve the enabling environment for community health workers. The government of Cote d'Ivoire must reaffirm its commitment to strengthening community health. And with PROPEL, we're part of the working team here. We want to identify, to leverage, and to advocate for opportunities to strengthen community health workers' working conditions. How? A few suggestions. First, from a financing lens, we need to increase their payments, at least to the country's minimum wage, and pay them, if possible, with domestic resources, just for the sake of sustainability and less dependency. We need to improve and formalize their legal status. We need to improve the geographic distribution of community health workers on the basis of epidemiological and demographic characteristics of the various health regions. And there are other examples that we can share that we do interesting work on that. Equip these workers with materials, with commodities, with equipment. And finally, and this is crucial also for our for our work in the next year or two, to include community health workers in UHC insurance schemes. And here we can be talking about district or community level mutual insurance. So in the next year or two as well, PROPEL, we want to be working with the Ministry of Health, very importantly, to build political will for the improvement of domestic management and also to improve payment processes for community health workers. And this will include the formalization of them as official health workers. Next slide, please. Quickly, in Botswana, in 2017, and in the context of persistently high child and maternal mortality rates, the government of Botswana launched the PHC-CHW coordination strategy and then published its guidelines to ensure that they are well coordinated, monitored, incentivized. The progress of the program so far has been varied, but there are different opinions on that. Relative success, we think, has been achieved in terms of recruitment, education, and certification of CHWs. But success has been more limited around remuneration, supervision, empowering, and again, financing. So what has PROPEL been doing? Many aspects on different fronts. We supported the MOH with an HRH baseline assessment. Why? This is crucial to then be able to develop evidence-based HRH strategies and to improve HRH planning processes. We also revitalized Botswana Multisectoral HRH Technical Working Group. Why? Because this will allow us to support them to identify an approved indicator for a wisdom assessment that will be developed quite soon. And we're basically exploring also with them ways to engage community health workers, so that then we can scale up community health workers within PHC. We're conducting a PEA, political economy analysis, and the intention is to then use the results and the findings from that analysis to address this issue in the PHC revitalization roadmap. One that is not mentioned there, but came up yesterday. We have also collaborated with multiple stakeholders in Botswana to upgrade the IHRIS, which is the HRH information system. And this is going to strengthen government officials' capacity to effectively use the newly upgraded system and then to be able to plan accordingly. So, as mentioned at PROPEL, we have a clear vision of the role that CHWs can play, through the right support on policy financing and advocacy as part of the HRH system, so that they can be a powerful player to shape the impact, not just of our programs, but also of health policies in general. So I'm going to stop there. Now it's time to hear from our colleague, Dr. Alex Herring. He is the Senior Technical Advisor on Health Systems for PROPEL Health, which is our bilateral USAID funded project in the Philippines. Dr. Herring?
Thank you very much, and hello, everyone. Next slide, please. In this presentation, we highlight the health system context where CHWs currently work, the general types of CHWs, and the national recognition they get, their varied roles they play in relation to national health priorities, and finally, the evolving governance and financing system under which CHW's performance can be further enhanced. Next slide, please. The Local Government Code of 1991 devolved the delivery and financing of health services to autonomous local government units. These include 81 provinces, 143 cities, 1,489 municipalities, and around 50,000 barangays. The barangay or village is the smallest political unit. Funding for the local health system comes from a block grant from the national government, supplemented by local resources. One implication of this fragmentation of local health system is that it creates inefficiencies in the allocation of health resources. And as such, it also, by extension, those inefficiencies extend to the deployment, financing, and management of CHWs across LGUs. Next slide, please. Next slide, please. CHWs in the Philippines typically include the barangay health worker and the barangay nutrition scholar. They perform varied roles on a wide range of health and nutrition concerns. The standard deployment is 1 BHW per 20 households and 1 BNS per barangay. The BHWs and BNS, who are volunteer workers, are officially recognized and are provided with incentives and benefits through national legislation. Qualitative studies report that the compliance of LGUs in providing these benefits and incentives has been uneven. This principally is due to the widely differing financial capacities of LGUs. Next slide, please. In 2011, the Department of Health launched the Kalusugan Pangkalahatan, or Universal Health Care, to attain the goal of universal access to quality health services by the poor, as identified by the Department of Social Welfare and Development. Part of that overall strategy is the mobilization of community health teams composed of the rural health midwife as the leader, the barangay health workers, the barangay nutrition scholars, and other community volunteers. The main function of the CHTs are to ensure early identification of health problems through health risk assessment and development of health plans, inform families of the benefits of PhilHealth, that's the social health insurance, PhilHealth membership, and help them seek health care from PhilHealth accredited facilities, and refer families for timely utilization of needed services. The DOH provided substantial funding for training and materials and for its eventual assessment. The assessment in 2015 showed variation in the performance by regions, and as might be expected in a devolved setup. But generally, the results were positive, at least from the standpoint of CHT functionality. Next slide, please. In 2018, the Philippines passed the Universal Healthcare Act, whose objective is to ensure equitable access to quality health services to all Filipinos without causing financial hardship. To improve efficiency in the provision of these services in a devolved system, the UHC Act provided for the organization of local health systems into province-wide and city-wide health systems. Province-wide or city-wide health boards shall manage the integrated system, including the pooling of resources for health in a special health fund. Next slide, please. The UHC law mandates PhilHealth to implement a comprehensive outpatient benefit package. In compliance, and as a start, PhilHealth implemented the Consulta Primary Care Benefit Package. The package consists of primary care services, provision of select laboratory diagnostic examinations, and select drugs and medicine. The Consulta benefit delivery process involves the following: the registration of beneficiaries to accredited primary care facilities, the conduct of first patient encounter, the consultation with the primary care provider who prescribes needed laboratory exams and drugs and medicines, and refer beneficiaries to higher levels of care if needed. The CHWs, BHWs, and BNS, under the supervision of a midwife or nurse of the health center, assist in these processes, particularly in the registration, conduct of FPE, do household visits to bring beneficiaries for consultation, and follow up beneficiaries' utilization of prescribed services and medicines. Next slide, please. A network approach to Consulta implementation is being tested in 4 provinces and 1 city, referred to as the Consulta PCPN Sandbox site. The term sandbox denotes its experimental character. In this approach, the LGUs form a network of primary care providers managed by the province-wide or city-wide health board. The PhilHealth contracts the network to deliver services to agreed-upon beneficiary target. The contracted amount is pooled into the special health fund. The health board then plans, budgets, and disburses this fund that allows for an equitable distribution of resources across participating LGUs to provide the needed Consulta services. More importantly, it allows for the adoption of LGUs across LGUs of a common standard on tasks and workloads for the CHWs to help the network achieve contracted targets in a province-wide or city-wide context. Next slide, please. We in our work at Protect Health see 2 examples of these networks, or at least an evolving network. In Bataan province, they integrated their primary care systems consisting of 12 LGUs into a province-wide network managed by the health board with support from the provincial health office. Capitation payments were based on network contract with PhilHealth, and the contracted amount is pooled into a special health fund. The total population of the target beneficiaries was 850,000. The contracted amount, the first tranche of which was paid by PhilHealth, that amounted to 114 million pesos. An integrated operational plan and budget allows for efficient and equitable distribution of resources for Consulta implementation, including the deployment of additional doctors, BHWs, and encoders, financing through the Special Health Fund, and management through the Health Board and the Provincial Health Officer of the management of the CHWs. In Davao City, the Health Board and the City Health Office provide policy and operational guidance. A plan to pool capitation payments paid to individual district health centers into a single trust fund to finance citywide service inputs, including additional physicians, BHWs, and encoders to accelerate citywide Consulta implementation. Finally, we discuss, next slide, please. Our technical assistance to the entire Consulta process. For PhilHealth, we assisted in the estimation of per capita cost of providing Consulta services as inputs to the design of capitation payments. In Davao City, we assisted in streamlining the Consulta process and training of PHWs and encoders to implement registration, first patient encounter, and navigation. In Cebu City, we assisted in developing operational plans for consulta registration, first patient encounter, scheduling of client appointments for consultation and referral. In Bataan Province, we assisted in the establishment of the province-wide primary care provider network in the first place, the fulfillment of PhilHealth requirements for contracting, and preparation of a supplemental annual operational plan for the utilization of capitation payments, including the hiring, deployment of additional VHWs, and establishment and utilization of the Special Health Fund. And for DOH and PhilHealth, more recently, we assisted in developing a framework for the rapid assessment of consulta implementation. With that, thank you very much.
Thank you very much, Dr. Heron. So now we will hear from our colleague there, Dr. Solange Hakiba. She's our health system strengthening expert, and she's also the former chief of party for our health system strengthening project in Rwanda, RISA project. Solange?
Thank you very much, Jorge. And hello, everyone. It's very exciting to be with you all to discuss this very important topic. So I'm going to share with you the Rwanda community health experience, but with the unique approach that our health system strengthening project has used to support the community health program. Next. The health system in Rwanda is built like pretty much all the different systems. But we have had a great emphasis in training the administrative level of our decentralized authorities. It was very important that in addition to the service delivery level or the clinical level, the facilities, the expert in health, our administrative population administrative colleagues know exactly what we do in health. So they've undergone through extensive training in health matters. And you could see that the more we train them, the more their response and their availability to answer the issues were also growing. Next. So when we look at the pyramidal shape of our health system, we see again, like everywhere else, that our community health workers are the frontliners. As such, we need to empower them and make sure that they have everything they need, because next, we can see that 90% of the burden of disease actually happens below the health center. And below the health center is the one of the closest health structure to our population. Next. With a population of 13 million inhabitants, Rwanda needed badly to strengthen the house-to-house approach. And since 1995, the community health program has been put in place. But it's only around 2005 to 2009 that the huge change has been happening with a benefit package focused on primary health care. It was not yet the name in that time, but it was focusing on the maternal and child services that was very, very bad. The indicators were very bad, and it allowed us to really change the trend in the indicators of the country. Later on in 2010, to the quantity of services that were being rendered, the Ministry of Health introduced a community-based health performance contract. The performance-based contracting was coming to not only add the quantity, but also the quality to the services that are being rendered to the population. Today, Rwanda has almost 60,000 community health workers, and those almost 60,000 community health workers serve 14,873 villages. We have in each and every village 4 community health workers, 1 devoted to maternal health, 2 a male and the female called binôme, who treat the other diseases, and 1 last community health worker who's devoted to health promotion. Of course, the package has always been promotive preventive and curative. But it was very important that as we move forward, we change the way they are doing the rendering services to be more innovative and higher impact, but also continuously encourage the service utilization to the facilities. Next. Now, what are actually our community health workers doing? From the initial package, maternal and newborn health services were available. Integrated community case management, nutrition, community-based provision of family planning, which has had a huge impact on the uptake of family planning in Rwanda, and the reporting of community health activities, drug management, tuberculosis, and malaria. As you can see, those are everyday services, some program services, but now the trend of the diseases has changed so much that it's important that a new package is added: HIV, mental health, non-communicable diseases, behavior change, and emergency response to epidemics. As we have seen, it came up very handy when Ebola struck, and all the countries saw how much information and response from the ground level was very important. Next. So what has worked for Rwanda exactly? Primarily governance, strong political will. It was important that the government takes the first step, but then again, ownership of the activities and clarity of vision. I will come back to clarity of vision because it will help us to keep our community health workers focused on their work. It will also make them on top of the business of delivering services. Decentralization and performance-based contract called Imihigo at all levels. Administrative level, the mayor needs to know how many women are dying in his constituency. The provider health center need to know how they're going to treat their patient, and if they have a stock out, how they request for help to resolve the problem. Mapping of the development partners, but specifically coordination at central level, at decentralized level, all the way down to the health centers who are overseeing the community health workers. And then training on financial management and integration takes us back to our ownership issue. It was important that financial autonomy and effective accountability and transparency trickles down all the way from the central to the decentralized level. And the support that has been given by the Health System Strengthening Project to remove the backlog of unpaid bills to the facilities from 90 days to 5 days had made a huge impact in increasing the utilization and the response from the providers, the availability of drugs and the services that are rendered on time. Next. Now, going forward, what are we expecting to be doing, specifically working on a complementary package? We'll have more community health work, one additional community health worker who will be supporting the new package and training the existing community health workers to make sure that they respond to the new needs. There's a new trend, it has to be addressed. The digitization of community health services is very key. If we get the information on time, if decision will be taken and treatment can be reviewed and reports are more accurate. The entrepreneurship mindset, by bringing all the community health workers within a cooperative and helping them to have an income generating activity, has been very helpful. The same entrepreneurial mindset has been taken across the health system, so that the private sector mindset, an entrepreneurial mindset comes in, even in the health centers, to make sure that they know, in addition to the financial autonomy and the training they have received, they know how to better manage the facility. Of course, utilization of the community-based health insurance. Community health workers, just like for family planning, have been at the forefront of mobilizing for universal health coverage, and that has been very key for them. And finally, prioritizing primary health care. By supporting the reforms within the community-based health insurance, we're able to make the cost per encounter more efficient and allow, as we move forward, we all say in our speech every day that donor support is decreasing. Now, how are we increasing domestic resource revenue mobilization? So this is by making the services more efficient and allowing the people to contribute slowly, gradually, changing the way service is being rendered. Next. And then, of course, the entrepreneurial spirit will also allow to have to promote public-private community partnership that will set, in addition to the community facilities, the health centers, new form, new type of structures that will be rendering services. And also those different services, starting with the community health workers, having a way of reporting to the health committees. In Rwanda, health committees are working at the health centers and they receive all the information from the community health workers. If they are digitalized, if they are organized, if they are trained, these health committees know how to work efficiently. And then creation of those dashboards coming back from the data that come from the community will be very helpful. And lastly, very important, keeping the citizen at the center of the care and making sure that we have satisfaction. That's why continuously quality remains at the center with the national scorecard for citizen satisfaction rates. Thank you very much. That's what I wanted to share with you.
All right. Wonderful. Thank you very much, Dr. Henry. Thank you very much, Solange. Thank you for sharing your insights and experiences in your respective countries and to share the challenges, but also the progress that has been made at integrating community health workers in different ways and through different channels into our health systems. So I think that now it will be a good time to to have some questions and discuss and keep sharing our lessons learned. So before I look into the questions on the chat, I would like to ask if maybe anybody from our USAID colleagues or Vina, if they want to ask any questions to our speakers. And in the meantime, I invite anybody in the audience, if you have any questions, please drop them in the chat box, and then we'll try to respond them as soon as we can. So USAID colleagues or Vina, do you have any questions for the speakers?
I just want to say thank you so much for such a great presentation. There's a lot to learn here from experiences in the Philippines and Rwanda. And a quick housekeeping note, I tried to enter my question into the chat. It appears it's disabled, so I think Q&A is the way to go in case folks want to drop their questions. I'll let others go first. Thank you. Thanks, Jorge.
Sure. And yes, that is correct. I just noticed that. Yeah. So you have to click on the Q&A icon instead of the chat. So there are a couple of questions. Let me start with the first one. There was a question by Alexis Mwanza. She's a student at UNC, and she's wondering if when it comes to the planning on the work being done with the CHW associates, if we integrate CHW through the early stages of the process, or they're basically just agents that will play a role in the planning per se. I don't know if Dr. Herring or Solange can jump onto that one.
Solange first.
Sorry, Jorge, can you repeat quickly because you were breaking?
Yeah. So the question is basically when policies are being designed that will integrate community health workers, or has it been the case in Rwanda that community health worker has been part of the design, whether that is the design or the conception of the program or the conception of the policy? Are they usually part of that process, or do they sort of like are just the ones that will end up implementing the process?
Thank you very much. As our community health workers are all gathered into cooperative, they have representatives. So the discussion will begin at the community level, at the health center level, actually, because the health center is the custodian of all the different activities that will start at the community level. And that brainstorming will go up. Now, it is very essential that once they have meetings at the central level, one or two specifically chosen community health workers, representative the other cooperatives, sit on the table and discuss. But all in all, the different, if it's an issue of package, that is also among the responsibility of the health committee. So yes, they are definitely part of the discussion.
Yeah. Yes. Also, in response to your question, one of the motivating factors of CHWs in the Philippines, based on study, is that they're motivated if they feel that they are part of the bigger health system, and also that they could contribute and discuss on the role that they play in the community. So, given those things, what would bring that together? Those motivating factors. How do we try to respond to that? In the actual experience of the Philippines, if we have a strong, focused national program, like the program to improve maternal and child care, in which the strategy being to form community health teams. So not just in a barangay, but across the provinces, across the regions. So it's a major effort by DOH. And so that focus allows CHWs to be working with other CHWs in a larger network. And that feeling of being part of the health system, I think, is a way to generate additional motivation. And the more recent example we mentioned, the networking aspect of among LGUs to implement the Consulta benefit package. So again, in a province-wide system, an integrated system, where the CHWs work with CHWs with other LGUs. So that gives them a sense of they are part of the larger, not only the health system, the larger network. And so it is in that sense that perhaps we can cultivate this sense of belonging, this sense of being able to contribute their ideas so that that would continue to motivate them to participate as CHWs. Over.
And let me follow up with that with another question, Dr. Heron. And in terms of financing and payments and recognition, where do you think that the situation of CHWs in Philippines is headed?
I mentioned at the beginning of the devolution, the government issued, in recognition to their work, issued legislation that provided them incentives and benefits. This included financial incentives as well as non-financial incentives that included training, career development, and even civil service eligibility. What happened in the early years of the devolution is that the studies show that there has been uneven compliance with that law. The LGUs are not able to provide, or maybe they don't like to provide. And the reason is that they don't have the resources. So with the great variation in financing capacities of LGUs, one can see why some may not be able to provide those benefits while others can. But things have improved over the years. And more recently, the LGUs have come up with a larger share of the national taxes. And so the block grants that they get are much larger than what it was before. So this gives them more financial capacity to provide these sets of benefits. So things are improving, and there are other motivational factors that we can tap other than working on the this initial constraint. So it seems that it's not as binding a constraint now than it was before. Over.
Right, thank you. And I see that there's somebody else with a hand raised. Let me ask very quickly one additional question to Dr. Solange. Solange, after hearing your presentation, I'm wondering, two questions actually. The first one is, why would you say that has been the most persistent challenge, even like until today, that that Rwanda is facing since the beginning of this CHW program? And two, again, moving forward, key reforms that should be prioritized to strengthen this program in order to maximize their potential impact.
Thank you very much. Very quickly, I think the most persistent issue that have been coming up is focusing the community health workers to health matters. It's such a big crowd of ground level providers that when we speak about their promotion, the promotion aspect of their work, all the other sectors want to come in and jam their responsibilities. It's very important to protect the time of the community health worker to specifically health, but also to integrate the activities enough to not verticalize them and lose their benefit and impact. Going forward, I think there will be a game changer with the new, I'll call it a bond between the human capital and the technology. They will bring us global health security information. They will bring us demographic data. They will bring us key information on a timely manner. And it's our responsibility to equip them enough so that they will start entering good data, and we have less work to clean up that data. Over to you, Jorge.
Perfect. Thank you very much, Solange. I see Naso Qureshi. You raise your hand, please. The mic is yours. If you can unmute yourself. Naso Qureshi.
Thank you so much. Sorry, I was not able to unmute myself earlier. Thank you very much for the two excellent presentations. USAID has been working with countries and a wide range of countries in Africa, Asia, and the Latin America and Caribbean region on highlighting what the national policy and strategy priorities are and mobilizing partners to act on those priorities and to really put governments in the lead. So I really appreciated your slides on how you're supporting countries to advance the agenda. My question focuses on, for both speakers, if you could talk a little bit about recent evaluations of the programs in terms of how well they are performing for coverage improvement and any tactical shifts for policy and or program priorities that have been highlighted for the programs themselves in thinking about the community health programs for the future next generation CHW program. So if you could speak a little bit about evidence and recent evaluations and tactical shifts about directionality of the programs looking ahead. Thank you very much.
Well, let me start and give, as an example, what I mentioned earlier, the strategy of mobilizing community health teams. The focus was on improving maternal and child care. And it was also the time when the national government was moving towards more facility-based deliveries. And improving the capacities of the medical personnel to provide these kinds of services. And it required a system on the ground that will help beneficiaries, pregnant women and children, to bring to the facilities. And so these community health teams, they actually had a rather, if we look at it as from outsider, it looks like a complex task of identifying health problems and health risk assessment thing, informing families of field health membership, the benefits of that. So that's a different kind of skill than what they used to in providing and promoting better care and so on. But in spite of that, what might be a new set of skills, more complex set of tasks, they were able to perform well in terms of their capacity to do the work they do. And this is based on the national assessment of the performance. Although, as we would expect in a devolved setup, there are variations across the regions. There was also a quarterly sample survey that looks at the work of the CHDs conducted by a USAID project for 2 years. And they found, as might be expected, certain gaps in certain of these activities. But on the whole, the process was working. Now, in terms of the consulta, it's still too early. We have our observations and things like that, the design and the effect. So what the project did was to assist in the development of a framework for rapid assessment so that field health can do the assessment or subcontract other agencies of government to do the assessment. And then we can find out what needs to be adjusted and how it can be better managed and financed. Over.
If I may share also a little bit about the Rwanda experience, is that, of course, like everywhere here in Rwanda, the community-based
I think, Solange, you got frozen. Maybe you can turn off your camera. Is Solange frozen, or is my entire computer frozen? Can somebody give me a yes or a no?
Solange is frozen.
Okay. So one thing that I was going to add is I actually did I believe it was a very light assessment on the evidence on the through multiple evaluations using quasi-experimental or experimental design that they were looking at the impact of community health workers. And what I remember seeing is that that the evidence is less conclusive when it comes to health outcomes, but it's mainly because it's harder to measure, right? Because then it depends on on the dosage, right? What is it that we're talking about in terms of dosage? Because for something like, an intervention with community health workers to have a very clear on health outcome, it cannot be, a visit to a household per month, right? That can have a very important impact, but then it's usually impacts that are harder to measure. So when it comes to community health workers, dosage is very important. And what we're seeing is that in some countries, the involvement and the engagement from community health workers is actually quite intense, which allows for this type of evaluations. But the evaluations that I had seen, for better or worse, they're mainly focused on performance evaluation, right? Looking at whether through different set of incentives, some community of health workers perform better than others, right? And those sorts of incentives can be an issue of formalization, formal recognition, payment, etc. So, but I take it that it's one of those areas that, considering how much time and how many people are excited about getting engaged on projects where community health workers are playing a key role, I think that that's a gap that is missing in terms of solid evidence on not just on whether community health workers work in terms of the effectiveness, but also to understand the enablers, right? How is it that they're working, for whom, under what circumstances, which is usually all this sort of useful stuff that makes these type of studies interesting. So I'm aware that we are 1 or 2 minutes after 10, so this may be a good place to stop. I want to thank our speakers today, Dr. Solange, Dr. Herin, Sunita Sharma, who introduced all of us. Our infinite thanks to USAID, to Vina Menon for your guidance, support, leadership, and especially to all of you who join us today from wherever you are. Thank you to Dr. Herring. It's almost 11 p.m. for him, so we appreciate that. And we hope that you found the content of this webinar interesting, useful, but especially inspiring. So until the next Web 10, and hope you all have a wonderful day. Thank you.
Thank you very much, Jorge. Thank you, everyone.
Thank you, everyone.
Thanks, bye.
Thank you.